All right, it's about that time, so we can go ahead and get started here. Thank you all so much for joining this afternoon. I'm really excited to have you all with us. Our November OSPF webinar is going to be Understanding the Nature of Military Culture, Combat, the Stresses of Transition, and Trauma Informed Care. My name is Emily Steinberg, and I am the Communications Coordinator here at OSPF. I have the privilege of hosting today's presentation, and I'm excited to welcome our speaker, Jeannie Morrison, the Community Engagement and Partnership Coordinator with the Suicide Prevention Team at the Chillicothe VA Medical Center. Thanks again for being here, Jeannie. Before we get started, I want to do a quick note on housekeeping. After today's webinar, we're going to send everyone a follow-up email with a link to the post-webinar survey as well as Jeannie's presentation. And this survey is going to be required for anyone who wants to receive either CE credits or a certificate of attendance. Now, I do want to note that CE credits are only available to OSPF members, but anyone can receive that certificate of attendance. I'll also include a link in that email with information on how to become a member if you're interested. Membership is valid for the full year and will include access to those CE credits, offering up to 12 opportunities annually. And all certificates will be sent within 30 days. At about 12:45, 12:50, I'll start the Q&A session, and you all are encouraged to please submit your questions through either the chat feature or the Q&A, and Jeannie, I'll keep track of those questions for you and read them off to you at that time. All right, let me introduce our wonderful speaker today, and then we'll get started. Jeannie Morrison is an independently licensed social worker who obtained her master's degree in social work from Cleveland State University and also obtained her master's degree in science of management with a focus on healthcare administration at Southern New Hampshire University. Jeannie began working at the Chillicothe VA Medical Center in 2008, and over the last 18 years, she has worked in residential substance use disorder treatment, a day treatment program for the severely mentally ill, provided individual and group post-traumatic stress disorder therapy, and other mental health therapeutic programs. Currently, she is the Community Engagement and Partnership Coordinator for the Chillicothe VA, where she works with the County Suicide Prevention Coalitions to reach veterans, their families, and service members. Jeannie is also the chair of the Social Work Education Committee and the co-chair of the Postvention Response Team at the Chillicothe VA. She's a certified trainer for QPR, VA SAVE, cognitive processing therapy, and social skills training. She's also skilled in using cognitive behavioral therapy. She serves as a clinical supervisor for non-independently licensed social workers. And in her personal life, Jeannie really enjoys spending time with her family and 4 dogs. Jeannie, whenever you are ready, please go ahead and take it away.
Well, thank you so much for that lovely introduction. Can you hear me all right?
Yep, you sound great.
Wonderful. Okay, well, I wanted to say thank you so very much to everyone for taking time out of their day to join us today. I'm going to work on getting my slides pulled up here. Give me just 1 second.
Perfect.
All right, how are we looking?
Looks great.
Perfect. All right. Well, as Emily said, my name is Jeannie Morrison, and I am the CEPC here. We're going to talk about military culture and trauma-informed care, but before we get into that, a couple disclosures. So these things that I'm talking about today aren't necessarily the opinions of the Chillicothe VA Medical Center, the VA Health Administration, or the federal government. I have no conflicts of interest. But most importantly, the information that I'm sharing today is based on my experience working with veterans at the VA. I was an intern for 2 years up in Rexville, and then I've been here 18 years. And I've used a variety of resources, but by no means is this exhaustive or meant to be, all encompassing. And just for the record, I am not a veteran. This is my way of serving. So if we do have veterans on who would like to clarify, jump in, ask questions on anything that I'm talking about, please feel free to do so. Before we get into the content, I just wanted to share what a CEPC is. So we are all across the nation at every VA facility here. We are social workers mostly, and we have 6 priority areas that we focus on. So we want to identify service members, veterans, and their families, or SMVF, which you might hear me reference. Improve screening for suicide risk, promote connectedness, especially post-military discharge, improve care transitions, increase lethal mean safety, and improve safety planning. And we do this in a wide variety of ways. I'm not going to go over all of those, but basically we serve as VA liaisons for our community partners. and our veterans getting them the care that they need. And I'm very humbled and honored to be part of the CEPC team. I could tell you here in Vision 10, we have some exceptional CEPCs. So what are we going to talk about today? So I'm going to talk a little bit about military culture. We're going to go over some challenges faced by veterans as they're transitioning into civilian life and things that might come up for them, such as PTSD, depression, and TBI. We're going to talk about what trauma-informed care is, but spend a good chunk of the time talking about the primary core values of trauma-informed care, how to incorporate trauma-informed care into your daily practice, and then a few resources and some clarifications on what the VA is and all of the different things under the same umbrella for the Veterans Administration. So first we have to know who we're talking about. So when we talk about veterans, there are 6 branches of the service. So there's Army, Navy, Marines, Air Force, Space Force, and Coast Guard. And there's asterisks by the last 2 there because Space Force is a newer branch. And so I've not encountered any veterans from that branch yet. And typically Coast Guard veterans tend to be around VAs, usually where there are ports or large bodies of water. They just tend to settle where they've served. So I personally have not treated anyone from the Coast Guard, but we do treat any veteran from any of the 6 branches. And another way to think about it is active duty, Guard, Reserve, and veteran. And a lot of veterans don't necessarily consider themselves a veteran because they didn't serve in combat. And part of what I like to do with the community partners are help them educate that don't ask, are you a veteran when you're screening somebody? Ask, have you ever served in the military? And that's going to capture those people, especially the ones that maybe didn't serve in combat or feel like they aren't a real veteran. And I use quotes there because they only served in the Guard or Reserve. But regardless of their service, as long as they meet qualifications for the VA, we will provide care for our nation's heroes. Some common challenges, and we're going to touch on a few of these, are reconnecting with family and friends, finding gainful employment, basic necessities, establishing healthcare and mental health services, adjusting to a different pace of life and a different culture when you're a civilian versus in the military. How you can relate to civilians can be a challenge as a veteran, rejoining your community, and a big one is finding purpose. So first, the overall transition to civilian life. It's not just a change of jobs. You aren't just going from your military job to civilian job. It affects every life domain. So it does affect work, but it can affect other responsibilities that you have. It can affect your home, your community, your lifestyle, and even your health care. Where you get care after you're out of the military can look different for everybody. We have to understand that there are drastic changes in the veterans' environment and life circumstances when they're coming out of the military, transitioning back to civilian life, and that this takes time and requires a period of readjustment that's really going to be different for everybody. No one's readjustment time is the same. For some, it can take a few weeks, few months. For some, it can take several years, and some may never fully adjust to being civilians. So we have to set realistic expectations and be patient with veterans. And veterans need to do this for themselves as well, that they're not going to go from being in the service to being a full-fledged civilian again, and everything's going to go smoothly and there's not going to be any hiccups or bumps in the road. So having a really good support system during any transition is immensely important. But, you know, dealing with the veteran population, I see support systems being the most effective when they include people from their personal life, but also people they've met while they're in the service and even VA providers. So it really is an all-encompassing support network that's really needed to make this transition as smooth as possible. So some structural differences: when you're in the military, it is very structured. You have a clear mission, there's a clear organization, there's a clear reporting structure. But think about civilians. So there's less structure, which means more ambiguity. So the amount of choices, everything you have to do for yourself, you have to set, track, and follow your own goals. You have to find your own employment. You're responsible for all of your own household duties. You're responsible for all your own self-care. When you're in the service, because of the way it's structured and built, like a lot of that's done for you. And so with more ambiguity for our veterans returning home, often comes more fear, anxiety, and difficulties with adjustment. So we talk about culture and pace. In the military, it's very collaborative and camaraderie based. Your battle buddies have your back no matter what, and you can always count on them. There's a very clear chain of command that dictates your schedule. It's very mission oriented. They kind of have their own language, the military does. That they love their acronyms just like the VA does, but they use kind of their own language to refer to things, how they talk to each other, how they accomplish stuff. So learning that jargon can be a big learning curve when you first enter the military. But then once you're programmed, so to speak, and have that jargon down pat, by the time you get out, now you've got to switch over to civilian life, which is more corporate lingo or job based or society based. And in the military, it's very authoritative in communication. You're told what to do. One of the favorite sayings I hear from veterans is hurry up and wait. So, like, you're told what to do and you hurry up and get there to do it, and then you wait till you can actually do it. Whereas in the civilian world, it's much more competitive. There's not as much connection. The camaraderie that people have in the military just isn't built in anywhere in civilian life that I've been able to find unless you join social organizations. There's more ambiguity and flexibility. Flexibility can be a good thing, but when everything's been dictated to you for however many years you've been in the service, and now you have to make all your own choices, and there are so many choices to pick from, that's where the problem comes in. You've got to have good time management skills. You're expected to be a team player. And in the military, your job is 24/7, even if you're not doing your actual job, you're in the military all day, every day. Whereas in the corporate world or the working world of a civilian life, you stop at 5 or whatever time, when your shift is done, you go home, you're done. It's not like that in the service. Talking about employment, so when you're returning to a job as a veteran and entering the workforce, it's really difficult to catch up on the skills. So you've learned all these skills and valuable tools while you were in the service, but what's been happening in the civilian sector? You may not necessarily have learned the same skill set and you need to now catch up. Technology can change. There are technologies that civilians use that military don't, vice versa. And even if you return to a job you previously held before you went into the service, a lot can change depending on how long you're gone. And if you're entering the workforce, say, your 17, 18-year-old kid goes straight into the service and served for however long your term was, and now you're out and getting your first real job as a civilian, you've got to look, apply, and interview. You have to create a resume. And where that can really be a barrier for our veterans is translating their military service and their military skills into civilian workforce skills. So being able to work with someone, maybe at the VA, like a voc rehab counselor, to help you figure out how to list on your resume all of your military skills, because you've got a ton of them and they are very useful, but it's translating it. And that's where sometimes that difference in jargon can really play a role. Excuse me. When we talk about basic necessities, military provides you pretty much everything. Your food, your clothing, your housing, if you're staying on base or deployed. And there's often little to no choice. You just show up and that's what it is. Whereas in the civilian life, it's self-provided, the huge array of choices, and like I said before, feeling overwhelmed or feelings of worry and fear that, potentially having so many choices can just kind of shut you down a little bit. So helping veterans understand you're not going to have everything provided for you, and how do you start making these choices in a healthy way when you're starting to feel overwhelmed and anxious. Some reasons that veterans may avoid pursuing mental health care, because a large majority of veterans don't come to the VA for mental health care. It may be because they're concerned they might be prescribed medications that have undesirable side effects. If they're still in, like, say they served an active duty and they've gotten out and then later go into the Guard or Reserves, they could come to the VA as a veteran from their active duty time, but they may still be in the Guard or the Reserves. And coming for mental health care as a veteran, they have concerns may jeopardize their time in the Guard or Reserves, or if they decide to reenlist into the military and it's been discovered they've sought mental health care, there is this stigma attached to it where it's going to be too hard to get back in, or they're going to hold it against me, or they're going to think I'm crazy. And I use that word because I hear it from my veterans. So they could be denied security clearances for ongoing military career. The big one, though, is they are worried about appearing weak or crazy to their peers. That stigma is alive and well, just like it is in society, but I think even more so with our military veterans. Service members are supposed to be strong and tough, pull themselves up by the bootstraps, and having mental illness isn't considered being strong to a lot of people, but it is a self perception. And I do a lot of education when I used to do direct care with my veterans about it takes more strength to ask for help. It takes more courage to say there's something that you cannot fix on your own than it does to try and figure it out by yourself, maybe make some unhealthy choices and have a worsening of your mental health issues. Some potential signs that there might be a mental health crisis, and I'm just going to go over these briefly because we're really talking more about some certain kind of issues that veterans may encounter. So really you want to look for a change. Is there a change in their personality? Are they going from being social to withdrawn? Are they going from being, out and about, dealing with daily life, grocery shopping, taking care of bills and errands, and then all of a sudden they don't leave the house for weeks at a time? Are they suffering from poor academic or employee performance, which can be affected by attendance? So, are they missing a lot of work because of their mental health issue? Are they missing classes if they're in college? Has there been a drastic change or even sometimes a subtle change in their appearance? We talk about depression, for example. Hygiene can suffer when you're in a depressive episode. And so, if you notice that a veteran's hygiene is getting worse, this might be a warning sign or a red flag that you need to say, hey, are you doing all right? Let me check in with you and make sure you're okay because, you seem more unkempt or you seem like you're not attending to your physical appearance as much. But also in their body language, their amount of eye contact, how they speak, are there changes in those kinds of things? Are they becoming more irritable, more restless, or more impulsive? We know a lot of times veterans or anyone with suicide risk, within the first 5 minutes of having the thought, they may impulsively act on the suicide thought and make an attempt. And so this comes from an impulse. It's not a thought out thing. They have a thought and bam, they just act on it. And a really big one, especially when we talk about PTSD, which unfortunately is pretty prevalent in our veteran population, is avoidance. So if I stick my head in the sand and pretend like it's not an issue, it'll just go away and not be an issue. When we talk about issues that veterans face, they're invisible injuries. And these are the ones that make it really difficult for veterans to seek care. Because I've heard, I can't tell you how many times from veterans say they delayed getting care at the VA or feel guilty for coming to the VA because they weren't physically injured. They didn't lose a limb. They don't have a major physical disability. But the invisible injuries that veterans carry with them, I think sometimes are far more problematic than the physical injuries that can occur during service time. And so we're going to talk about depression, PTSD, and TBI. But interwoven into these three are also substance use and abuse issues. And then we'll touch briefly on suicide. So it was in the email invitation that got sent out with this webinar, but we've lost more veterans to suicide that served post 9/11 than we did in the post 9/11 conflict. So we've lost more veterans to suicide than we did in 9/11 conflict. That's quite a difficult thing to think about when we think about the thousands of lives that were lost during war, which is unfortunate but kind of expected. But the real war is the one that's being fought at home. So what do we look for? Well, first you want to look for extreme anger or any sort of violent behavior. You want to look at serious thoughts of hurting yourself or others. And as I stated, suicide is a huge killer of returning veterans, whether it's because they can't handle their mental health struggles, or they have physical disabilities, or they just can't adjust to civilian life. There's lots of different reasons. Um, a big one that can affect sort of their coping mechanisms is having a decreased interest in pleasurable activities. And while this may not sound like a big deal, and it is something we look for in depression, when you're feeling overwhelmed, when you're feeling anxious, when you're feeling like you have decision fatigue, having a hobby, having something to distract you, something that you enjoy, something that's stress relieving can really be a beneficial coping tool. And if you're struggling with depression or even PTSD or TBI that can also have this decreased interest in pleasurable activities, there's not that coping mechanism there. With PTSD, there's often frequent nightmares and intrusive thoughts. And then for substance use, so no person ever uses a substance for the first time and says, I want to be an addict or an alcoholic. For people who struggle with mental health, it is a form of self medication, and sometimes has unintended consequences of pain control method. So, physical pain or psychological pain, you use a substance and all of a sudden you don't feel physically as bad. You don't have to think about mentally what's been going on with you. And so it becomes sometimes the only coping skill that a veteran is able to access. So it's not a sign of weakness if they become addicted to a substance. It is simply a self medication avenue that perhaps got out of hand. So when we talk about PTSD, trauma is an experience that overwhelms the ability to cope. So someone has experienced an event that involves actual or threat of death, serious injury, or physical integrity of themselves or others. PTSD can occur when you're exposed to a traumatic event, but not every event is going to lead to PTSD. All traumatic events can have a lasting impact on coping in everyday life, but it doesn't mean you'll come to meet the diagnostic criteria for PTSD. We also have to remember what may be traumatic for one veteran or one person may not be to another. We have veterans who have been through some horrible things. I can't even begin to tell you some of the things I've heard in therapy sessions. And it's small things that they seem to struggle with. Or a veteran who experienced what would be considered a minor injury during a training exercise may develop PTSD, diagnostic level PTSD. So we can't just say, oh, this wasn't traumatic enough, so you shouldn't have PTSD. Just remember, it is how the person is able to deal with and internalize and make sense of the traumatic event that has happened to them. And when we talk about trauma responses, there's the fight, flight, freeze, or fawn. So these are just some things to look out for, but really not going to get too much into like the diagnostic stuff or the symptomology. But it's important to keep these in mind because someone who is living with PTSD or someone who has lived through a trauma and is struggling with it, maybe not all the way to the diagnostic level where they meet full criteria, can still exhibit some of these trauma responses, and it impacts every area of their life. So if you have a veteran in front of you who is overthinking everything or who is having difficulty setting boundaries or easily gets overwhelmed or is controlling and comes across as a narcissist or gets stuck and can't always make good decisions, consider that it's because of a trauma, and it may be a trauma that you have no idea occurred. Research has found, so there's something called the ACEs, the Adverse Childhood Experience measure. So amongst all veterans, there is a high rate of greater than 4 on the ACE score. And as you go up in number, the worse your childhood was, basically, if you're not familiar with ACEs. But we know that male military service members, doesn't matter what era they served in, have a higher prevalence in all ACE categories compared to their civilian counterparts. So what does that mean? Does it mean that veterans have a worse childhood? Maybe. Maybe a veteran has a bad childhood and the way to escape it and to get out of their circumstance is to join the military when they're right out of high school. Or is it because when the ACEs is given to them as an adult, they've already experienced trauma and it sort of leaks into their childhood memories. And once they understand what trauma is, now they're answering these questions going, yeah, that happened, or yeah, I experienced that, or maybe they found a provider that they're more comfortable with. Lots of different reasons. We also know that up to 93% of female veterans have experienced some type of trauma. And the lifetime prevalence of PTSD is at least 23% in veterans who use VA care, 7% of veterans who do not use VA care. I suspect the 23% is higher, so is the 7%, especially the 7%, because if you're never screened for PTSD, how do you know if you have it? If you're not disclosing it or seeking mental health care, and the VA can't really track that kind of data successfully. Another concern for returning service members is traumatic brain injury. So this is basically a concussion. You know, if you hit your head too hard, you're going to concuss yourself. But when we talk about TBI in the military, it often comes from not just hitting their head on something, but more often will come from what's called a percussive injury or blast or shock wave from IEDs or RPGs, which are improvised explosive devices or rocket propelled grenades or other explosive devices they may encounter. And we have to keep in mind that percussive injuries like an IED or an RPG blast can also cause injuries to other body systems. So it can mess with their hearing and give them tinnitus. They can have pulmonary contusions and have difficulty with breathing. It may injure, other parts, musculoskeletal kind of injuries. So it could come along with a lot of physical pain. But the symptoms of TBI, I just wanted to review briefly because we see PTSD and depression pretty commonly in the civilian population, but I don't know that we really look for TBI or encounter TBI in our civilians as much as we would our military population, just because the prevalence of them experiencing a percussive blast. So things you want to look for: frequent headaches, having issues with confusion or anxiety or apathy. So maybe their affect is kind of off. Having episodes of being lightheaded or dizzy. After the TBI, having major changes in mood and behavior where there's this level of disinhibition, the part of their brain that tells them, I ought not to do that, or I shouldn't say that, or this is not a good idea, has been injured and can't always kick in and say, you know what, you really ought not to do that, or you really shouldn't say that. And so it just kind of comes out and happens. They have a lot of issues with sleep, a significant amount of trouble with memory or concentration. And this is really more geared towards what part of the brain was injured. But they can have chronic nausea problems, problems with vision and hearing, and not just because of the tinnitus that may be caused by the percussive blast. And then also, depending on the part of the brain that's affected or how severe the TBI was, they may also experience ongoing seizures. So why is all that important? Well, it's important to know what trauma-informed care is when you're dealing with a veteran. We just talked about the prevalence of trauma, especially in our female veterans. Up to 93% it's considered to have a traumatic experience if you're a female veteran. So we need to be trauma-informed. And what does that mean? Trauma-informed simply means that we act in a way that treats the person in front of us like they may have had a trauma, and we're going to work really hard not to re-traumatize them or trigger them. So when you think about trauma-informed care, it's just good patient-centered care, but it aims to make sure that any policy, any procedure, any environment that our patients may be in are healing, empowering, and aid in recovery. and reduce practices that can cause stress or remind people of prior traumatic experiences. That's the official definition. It is strengths-based, so it's really rooted in the impact of trauma and safety, whether it be emotional, physical, or psychological for patients and the people that deal with them, because secondary trauma is a real thing. You can get trauma fatigue. When I worked doing only PTSD therapy for 3 years in our Wilmington clinic, it was exhausting. It was really difficult. And if I hadn't had such good coworkers and supervisor and great self-care, that really could have had a negative effect on me. So good trauma-informed care can also be good self-care for the provider. Why is it so important? Healthcare in general can be very triggering and re-traumatizing, whether it's the environment. I mean, think about the last time you drove to a large hospital. Can you find parking? Is there construction that may remind you of environments that you were in that caused your trauma? You're being asked to disrobe and being touched by a doctor, even though it's in the confines of a medical appointment, that can still be very unsettling. There's concerns about stigma, having to share your story over and over again with each new provider, not feeling like you have lots of choices or options, being concerned about mistakes being made, being mandated to do something or mandated that something can't happen. And veterans may become triggered and easily overwhelmed. They may withdraw and shut down during appointments, or on the other end of the spectrum, become very easily frustrated and irritable. And a lot of times, how their appointment goes decides whether or not they engage in any future appointments, either with that provider, that facility, or healthcare in general. And a lot of veterans struggle with behavior change. Transitions are difficult to begin with. And when you add in behavior changes that a physician is asking you to do for your medical well-being, or a provider is asking you to do for your mental health well-being, that can be overwhelming and very difficult to do. The core values of trauma-informed care, and we're going to touch on each of these, is safety, trustworthiness, transparency, peer support, collaboration and mutuality, empowerment, voice, and choice. And this just came from the resources that I use. So this doesn't mean this is all of them or that every resource says that this is the core value, but these are the ones that I selected. So when we talk about safety, it's going to be physical and emotional safety. So think about ways when you're in your office environment, or when you're seeing a client, or when you're dealing with somebody that's standing in front of you and you're talking with them. What are some ways to create a sense of safety in that space? Is it environmental safety from physical harm? Is it emotional safety where individuals feel respected and valued? So let's talk about physical safety of spaces. So we want to make sure that the environment is clutter-free, well-lit. Furniture creates open spaces to avoid potential obstacles, especially when you're dealing with a veteran who may have PTSD. They'll know where all the exits are and how to get to them, and not put their back to a door. And some don't like the door closed because it can bar their escape if necessary. So there's that flight piece. Is there privacy? Are there private areas for consultation or appointments? Do you use soundproof rooms if you have them? Are there private restrooms or dressing areas? How safe are your environments? Do you have cameras? Do you check for hazards like broken furniture, exposed wires, and address them promptly? Veterans will see those things and see them very quickly and have some concerns sometimes. And is it accessible for veterans that have disabilities, whether that's ramps, handrails, elevators? Even if it's not an injury we can see, a disability we can see, there may be physical limitations, and having that accessibility is important, but also having clear signs to help them navigate the space. One thing I hear a lot about the Chillicothe VA, we are a huge spread out campus. And our building numbers are not very intuitive. They go from 211 to 35 to 18, 3 buildings close to each other. So trying to find your appointment or your provider can be very difficult. So the more signage there is, the more accessible it is to folks. When we talk about emotional safety, Are we creating an atmosphere that has comforting colors or artwork or plants or natural light or all of the things that make a space feel welcoming and comfortable? Are we greeting individuals in a way that makes them feel respected from the time they get in the space? So that would, start with the maybe the clerk that's dealing with them or whomever answers the phone or whoever gets them to you if you're the provider. Um, are we consistent in our routines and schedules? Do we always tell our veterans what to expect during their visits so there's no surprises, which can be incredibly triggering? And are we using respectful language with a non-judgmental attitude? When we're dealing with people who have mental health issues, we have our own preconceived notions. We may have our own ideas of how they can fix things, and they may choose not to go that route. And we need to check our judgment at the door and become good listeners and validate that what they're going through is difficult and that's okay. We also want to provide choice. So allowing individuals to make choices and control their environment as much as they can. They talk about when you're new to social work, for example. I heard a lot about never put a client between you and your door. Well, the way that a lot of these offices are set up here at the VA and a lot of other places, you don't have that flexibility or that choice. But are the seating arrangements, the lighting levels, are they more conducive to your patient safety? Like, especially if you're dealing with somebody who has a TBI, they may be very sensitive to light. So can you dim the lights in your space if you know you have somebody like that coming in? Are we using open-ended questions? Are we avoiding being confrontational or accusatory if at all possible? Sometimes confrontation is necessary, but not for every conversation. And we have to be aware of our body language. We communicate about 70% of what we're saying without what comes out of our mouth. It's our nonverbal cues. And then are we avoiding triggers with the environment, like certain smells, loud noises? And our staff trained to really pay attention to when someone is in distress or uncomfortable in their space. We also want to talk about trustworthiness. If the ball is dropped, even if you didn't do it, take accountability, apologize, and make the correction. It's important that they get what they need. It's not important that we blame who dropped the ball in the first place. But anytime we are, say, even doing a physical exam with someone, we have to ask permission. We need to fully explain and answer questions at every stage. The what, where, why, how, and when, narrating your steps so that they know what's going on. And letting them know they can have another staff member present if that makes them more comfortable. When we're talking about documentation after a session with a patient, a veteran, the language that we use is very important. It should be first person. So saying an individual who is experiencing homelessness instead of saying the homeless veteran. Using phrases that are objective to describe what happened, like patient missed the appointment due to oversleeping instead of patient was a no-show, or using language that is more not sensitive, but gentle, I guess is the right word. So instead of saying patient refused or patient is malingering, you could say patient is struggling with whatever. So making it about the behavior and not them as a person. And try to limit labels. So don't say schizophrenic or addict or use a lot of jargon. When we talk about collaboration and mutuality, we want to really be a partner with our veteran and share the power. We can come across as being in charge sometimes just by nature of what we are doing, and the power dynamic is automatically set that way. So becoming a partner and sharing the power, making the veteran as involved in their care as you are is very important. And we want to offer them lots of choices if we can. So again, strength-based, coming from a place of their resilience instead of what's wrong with them, making the care individualized as much as possible, and then promoting autonomy. So encouraging individuals to be participants in their care and not just wait for the provider to tell them what they should do. We also want to involve peer supports. Peers are incredibly important because they encourage connections with others that have similar experiences. So a peer has lived through being in the service, for example, and can talk to a veteran who is just getting out or who maybe is struggling with adjustment to civilian life or with a mental health issue. Hey, I lived through this, and here was my experience, and here's what helped me. Here's what I found to be beneficial. Here are the struggles that I encountered or the barriers that I encountered and how I overcame those. That shared experience is invaluable. And they also have their own core values like safety, trustworthiness, choice, collaboration, and empowerment. So there's a lot of similarities between a peer support and like a licensed provider because the relationships are very different, but both equally important. When we're talking about implementing trauma informed care, it should be system wide at all levels of the organization, from policy making all the way to service delivery, because how we set up success is very important for the whole organization, not just the provider seeing that veteran. You know, the environment, the modification of space, a lot of times has to come from top down. Staff support. It's important that the organization provide support and training to their staff to help them manage their own stress and trauma exposure, like I mentioned earlier. Keep in mind some cultural, historical, and gender issues within trauma informed care. We want to be culturally competent, so understanding that culture and historical context play a role in each person's experience of a trauma. We want to be non-discriminatory, so we avoid stereotypes and biases. And then affirm respect each individual's identity, including gender identity and sexual orientation, to the best of your ability. Be aware and respectful towards cultural differences when it comes to communication, behavior, and preferences. You know, what a veteran may want or need can be different from civilian life, but this is where you just got to see the person for the person. Because yes, they're a veteran, and that might be why they're in front of you, like if you work at the VA, but they're a human first, and their culture is what they bring in with them. We also need to make sure that the environment around us, like our posters and our display things and our brochures, reflect the diversity of those we serve. If you are in a diverse neighborhood, you don't want all of your pamphlets to have only white men on them. Or if you work exclusively with women, you want to make sure you give opportunity on your artwork or your posters for women of color or minorities or even men. Sometimes, you know, be diverse. Not men, I'm sorry. Different backgrounds. So kind of highlighting that. And try to be as gender inclusive as possible, using gender neutral language and respecting the preferred pronouns, and have private spaces for those who may not feel comfortable in gender specific areas, especially when changing for an exam or using a restroom. Integrating policy and ongoing education is important. We got to continuously learn about trauma and its impact on people and provide training for all staff members, and that's a top-down philosophy. So these are some resources for trauma-informed care, and you'll be able to click these links when they send out the slides, but this is just a few places that I pulled some of this information from. Now, if you do encounter a veteran who is in crisis, try to engage them in conversation. Make sure you bring up your concerns and why they're concerns. Don't be afraid to ask the question, are you thinking about killing yourself? And if you get a yes, stay calm, involve their support system, involve your resources, but be aware you are now part of their support system. But the key part is to listen, listen, listen. Because we need to be willing to stay with them if they have disclosed any plans to harm themselves or someone else. If you aren't the person that can provide them the help they need, get them to the help that they do need. You can call the crisis line together, 988 option 1 for the veteran crisis line. There's also text. Now, 988 did replace the 800 number, but the 800 number does still work. Okay, so now, I'm sorry I'm talking so fast, but I want to get through my little bit of resources before we go to Q&A. So there is a few different branches under the Department of Veterans Affairs. First is the healthcare side of the house. So this is going to be like primary care checkups for preventative care, screenings for depression, PTSD, substance abuse, military sexual trauma, housing insecurity, suicide risk, and then exposure screenings for presumptive care. We have inpatient and outpatient treatment for both medical and mental health, pharmacy, and a women's veterans health program. This is not an exhaustive list, but this seems to be the ones that are utilized the most in my experience. Now, the VBA, the Veterans Benefits Administration, is part of the Veterans Administration, but they are separate from the hospital. So, same umbrella, different service, if you could think of it that way, like branches of the military almost. So, they help with service connected, non service connected pensions, GI Bill benefits, voc rehab, and then some other benefits that veterans are entitled to. And thirdly, our vet centers. Vet centers can provide a lot of counseling, outreach, and referral services to veterans and their families, whether it be for individual or group therapy, MST, they can do family counseling. They're often liaisons between the VA and community resources. Services are free of cost, strictly confidential. They are not part of the VHA, so the VA Medical Center. They document totally separate from our record keeping system. And lastly are the Veteran Service Officers. So these are actually state employees of the Ohio Department of Veteran Services. And they can provide assistance with filing for a claim, because that can be a very difficult process to navigate, as well as filing for an appeal if the service connection is denied. They can help apply for an upgrade to a discharge status, financial help, and travel for appointments. Those are asterisks because that is available in some counties, but not all counties. So every county in Ohio, all 88 counties have a veteran service office, but not all 88 counties provide the exact same benefits. So you really have to contact the Veterans County VSO to find out what they are eligible for through their office. All right. Well, thank you so much for listening, and I am excited to hear if we have any questions, Emily.
Yes, we do. We have two great questions. And
Okay.
thank you again, Jeannie. That was so much valuable information. So the first question is related to PTSD specifically. Our guest asked, can you please clarify how the fight, flight, freeze, and fawn responses relate to PTSD? Do all people with PTSD exhibit these responses, or are they protective reactions that occur in response to perceived threats originating in the limbic system?
Wonderful question. So I'm going to try and get to all parts of it, but if I miss something, please bring me back around. So yes, the fight, flight, freeze, or fawn is a reaction to the trauma. It is how the person has been able to deal with, process, navigate their environment or their thoughts. It's not something that's done consciously a lot of times. Like, for example, when I worked with Vietnam veterans in Wilmington doing PTSD therapy, for some reason, a large majority of those particular veterans didn't really struggle, they thought, with PTSD while they were still working. Their symptoms only became problematic to them when they retired or medically had to stop working. Oftentimes, being a workaholic is a way to not have to face or deal with or think about your trauma. Same thing with fight. If you're always having anger outbursts or always trying to be in control of everything, a lot of times that can be a response to feeling threatened. And so you're going to fight back. Or if you feel threatened, you're going to flee. This is a part of the sympathetic nervous system. It's not a mechanism that we necessarily control consciously, but we can learn to tune it down so that every perceived threat doesn't feel like it's an IED or an RPG coming at you. It's just traffic, or it's just someone was rude to you in the store. It's not an actual threat. What other parts of that question should I hit on?
I feel like you answered it pretty well. Let me
Okay.
double check. Yeah, you responded about how it relates, and then do people exhibit these responses all the time, or is it something that just happens
Oh,
when they have a
yeah.
perceived threat?
Yeah. Perceived threat. Yeah.
Awesome. Okay, and then we've got another really great question. This one is about kind of preparing these veterans. So, our guest asked, what steps are being taken to prepare service members for the transition to civilian life before they leave the military? Are programs in place to set these realistic expectations for veterans and their families and to provide that mental health guidance proactively rather than relying primarily on the post-discharge services?
Very good question. So yes, the military does have a kind of program where when military members are getting out of the service, it's like within the last month or 6 months of their service time, somewhere in that time frame, if I remember correctly. And each branch does it a little differently. Where they try to say, here are your resources, here's the VA, here's things you should look out for and stuff like that. But from what I've been told from the veterans I've worked with, it was towards the end of the time they were in service. They wanted to get home. It was sitting in a classroom for large amounts of time, and people would kind of tune it out. So, a lot of the veterans that I talked to said they did not find it incredibly helpful. It didn't really feel like it set them up for success. Um, and so, we have a program here at the VA where we try to work with military branch or bases to help someone getting out of the military transition seamlessly into the VA so that they have all of that follow up care set up. And so that's pretty successful. But both the VA and the military, I think, could do a much better job of helping with those transition difficulties. And so having community providers educated on what to look out for transition difficulties can help the service member coming out, like if they choose not to engage in the VA, for example.
It's great. Thank you. Those were the two questions we had from the audience. We probably have time for about two more if anyone else wants to chime in. I actually have a question that kind of piggybacks well off of the last question we had. I'm curious how can, whether it's civilian agencies or the communities, how can we better support our veterans when they're going through these transition periods, especially if we're not the experts on veterans specifically, like you all are at the VA? What can we do? Is it just helping spot the signs and being their support system, or is there any other ways that we can collaborate better together to support these folks?
Yeah, so it's learning the signs, it's becoming educated on what veterans may struggle with that the civilian clients you're well versed in seeing may not struggle with. So, it's education and then it's putting it into practice. It's also being authentic. A veteran will spot someone who is not genuine in a nanosecond. And so being genuine, being authentic, and saying, I don't know what it was like for you to serve. I don't know what it was like to be in the military. Can you educate me on what it was like for you? Can you help me understand what you feel your struggles are so that I can figure out how to partner with you and walk through the journey and help you with it instead of saying, oh, I did this one webinar and so now I know certain transitional struggles and I'm the content expert. Like even at the VA, we're not content experts. And even a provider who is a veteran may not be a content expert on that veteran across from them's experience in the military because it is so unique and individual a lot of times. So it's also remembering while yes, veterans may struggle with specific transition difficulties, they are still just people too. And so if you treat them as a good provider like you would anybody else, with the caveat of keeping in the back of your mind they have these unique experiences that civilians don't, I think that's the best approach.
That's really helpful. Thank you. And Shauna mentioned in the comments that STAR provider training is
Oh,
also
yeah.
a resource. Can you speak to that, Jeannie?
Yeah, I'm not super familiar with STAR, but I know STAR will train civilian providers to provide mental health services to veterans. I believe you go on like a registry of some kind or get a certification, and you can be sought out or partner with the VA, I think.
Excellent. We just had another comment pop up, and I think this was a good response to tagging on to the question about what's happening while they're still in the military. Are they getting the resources they need for when they leave? Tracy shared vets I've seen have developed some level of distrust of the military, and that's why they aren't seeking services through the VA. The military not preparing them for discharge creates yet another reason for that
Yes.
distrust, which is sad.
Yeah, and that's something that the VA has been working on. I've seen great strides in the 18 years I've been here because if you think about Vietnam era, um, they did not become well received. They did not have a good experience returning home from society, and then the VA didn't do a very good job of making them feel welcome or providing them care either. And so we are trying to also kind of fix our perception as an organization that makes veterans want to come here for their care. But my philosophy is I don't care where a veteran goes for care as long as veterans get care. And so that's why we have things like community care referrals. So let's say a veteran, can't get into a VA service within a reasonable amount of time. We can refer them to the community and have a community provider provide that care for them. So it's relying on things like that. It's also having partners in the community that are willing to refer to the VA, even if a veteran is hesitant, and say, hey, look, even if you had a bad experience one time, it doesn't mean it'll always be that way. You've earned the right to get these services for free or for a very low copay, whatever tier you fall into at the VA. You have earned them and you really should access them. And sometimes it's just helping them understand that one bad experience doesn't mean every experience is going to be that way because they do tend to catastrophize a bit in that regard.
Yeah, that's really helpful. And we've got a great discussion in the chat about STAR training. So this is wonderful and everyone's sharing resources, which we appreciate. All right. Well, I believe we can wrap it up there. I want to thank everyone again so much for joining us, and I really hope you found this session informative and helpful. Jeannie, you shared so many great resources. So thank you again for your presentation today. And in that follow-up email that we'll send that post-webinar survey as well as the slides that Jeannie shared, which have got so much great content in them. And as a reminder, completing the survey is required if you want to receive those CE credits or a certificate of attendance. And CE credits are available only to the OSPF members. So if you're not a member yet, I'll include the link to join if you're interested. One final note before we go, I wanted to give you all a sneak peek of what our December webinar is going to be. The topic is the stress of agriculture and farming and how mental health professionals and communities can support farmers during those difficult times, which is so important for our Ohio communities specifically. This is going to be on December 11th at 10 a.m. and is going to feature two wonderful experts from Ohio State. Thank you again all so much for attending and for your contributions, your questions, and we hope to see you all next month. Have a great rest of your day. Bye, everyone.